I bring this up because I want to point out one small difference between cardiac output and blood pressure, cardiac output and flow. Now, cardiac output is the amount of blood expelled by the heart. Okay, we know that. It's a rate at which blood is expelled. But whether or not that blood flows depends on pressure, depends on the vasculature. So, imagine that there is a free beating heart in the middle of a room or on a desk like this. Right now it's beating at a certain rate. It looks way smoother on my screen than up there, but it's beating at a certain rate with a certain stroke volume, giving us a certain cardiac output. Is that blood going anywhere? No, it's just going to fall on the table, it's going to pool there, it's going to fall on the floor. It's not being distributed. It's not flowing anywhere. There's no pressure, there's no resistance, there are no tubes, there's no conduits. It's not going to go anywhere. It's only... that served its purpose. I want you to think of blood coming out of the aorta right here, dumping on the table. It's not going anywhere. There is a cardiac output, but that doesn't result in flow. To understand flow, we saw equations like this. At the end of last week. We saw these on Thursday at the end of last week. And in order for there to be movement of that blood, in order for the blood output by the heart to flow through the vasculature, you need pressure. In order for that cardiac output to become blood flow, you need pressure. If you have pressure, you will get more flow. Those are proportional. If there's resistance to that flow, if we have resistance, flow will decrease. And resistance we talked about being how big that system of tubes was, how much space there was in those tubes, whether they were constricted and opposing flow, creating resistance. So Q, cardiac output, is the rate that blood is output by the heart. Whether it flows depends on pressure. Just ejecting blood from the heart doesn't mean that it's distributed to any organs, to tissues, the liver, the muscle, bone, etc. Whether it flows depends on pressure. We know how to calculate this value. It's easy. Expressing this equation as such causes a bit of a conflict. Q is heart rate times stroke volume. We know this from looking at the physiology of the heart. But Q is also apparently pressure divided by resistance. So we rewrote this equation in an attempt to help frame our understanding a bit better. And it's in terms of pressure, because pressure is the regulated variable in the cardiovascular system. Pressure is what we're trying to maintain. Pressure is what makes sure blood moves according to pressure gradients. Pressure is what we are trying to develop, to produce. And how do we produce pressure? We produce pressure by modifying cardiac output or by modifying resistance. The only way that we can produce pressure in the vasculature is to modify how much is being introduced, blood, through modifying heart rate and stroke volume, and or changing the space, the size, the resistance of that vasculature, the resistance to flow. So yes, cardiac output, the rate that blood is pumped But if blood is ejected, it doesn't mean that it flows. It only flows if there's a pressure gradient. And the whole point of this section is trying to understand how we create and maintain pressure within the arterial system. So from the body's point of view, the equation, I think, makes most sense written like this. Pressure is what we're trying to maintain. We do it through these two ingredients. We don't actually have any systems in place that directly affect pressure, the variable pressure. Any change in pressure that occurs is secondary. We don't have control over pressure, but we have control over those other two ingredients. So, building on our understanding of how we modify cardiac output, we're returning back to the cardiovascular center. Same exact center. A lot of the same inputs and outputs as well. We've already seen this output. The parasympathetic and the sympathetic branches of the autonomic nervous system. We know that removal of the parasympathetic branch helps to alleviate the inhibition on heart rate. We know that activating the sympathetic branch will increase heart rate, will increase contractility. All of those things are to increase cardiac output. That's one of the ingredients in our pressure equation. And we've seen this already. This is not new information. What is slightly new information is that the cardiovascular center in the medulla, while it also affects the heart directly, it has efferent fibers that reach the vasculature as well. So whatever the signals are that are incoming that cause a change at the cardiovascular center, and we'll talk about those in a second, they are there to regulate pressure through the mechanisms we talked about already that regulate cardiac output. And then through a separate branch of the sympathetic nervous system that constricts the arteries, constricts the arterioles. This is the branch that vasoconstricts and increases resistance, or modifies resistance. Let's think about it that way. If I have information on hand that there's too much resistance, this branch will deal with it. If there's not enough resistance, this branch will deal with it. So we have the two ingredients to our pressure equation as we rewrote it on the last slide. These are the effectors of that cardiovascular center. Both of these things aim to maintain pressure. Notice that none of the tools in our toolbox do anything to pressurize or increase the pressure variable of the blood. It's always through changing cardiac output or changing resistance. So we've seen 2/3 of the effector side, the output side of the cardiovascular center. We've also seen a lot of the inputs when we discussed cardiac output previously. I'm going to emphasize one of these today in a bit more detail. We acknowledge that there's some superseding, overriding brain center that makes the decision to exercise. Remember I told you that if you measured heart rate while sitting on a bike versus standing beside the bike, there's going to be a 10 beat per minute difference. For some reason, the higher order brain centers know that you're going to start exercising. You made the choice to start exercising. And we have input from those centers to maintain cardiac output and to maintain pressure. Now we start to look at the other inputs in a bit more detail. We have direct feedback from the limbs if we're exercising, from baroreceptors, which monitor pressure directly, and then from chemoreceptors, which we've all talked about already. We know that these deal with changes in pressure or changes in the chemical composition of blood. We know what each of these sensors is supposed to respond to. Being that pressure is the regulated variable, the most important input are those from the baroreceptors proper. These are specialized groups of cells. They're in the arterial walls, and I'll show you where some important groups of them are coming up, that measure pressure directly. Well, it's not technically true. They measure pressure indirectly, and that will be clear on the next slide. But they measure pressure, and the information on pressure is used to determine, do I need to turn cardiac output up or down, or do I need to turn resistance up or down? Pressure is controlled. Pressure is compared to a normal comparative table. And then these are our effector branches to make sure pressure stays normal. So let's explore this idea of the baroreceptors a little bit. Pressure is the regulated variable. The things that sense pressure are probably pretty important in its regulation. These are pressure-sensitive neurons, in a sense, but really what they measure is the stretch in the walls of the arteries, stretch in the vessel walls. And stretch in the vessel walls is directly proportional to pressure. If you have more pressure in the vessel, there's more stretch in the walls of the vessel. If you have less pressure in the vessel, there's less stretch in the walls of the vessel. So the baroreceptors specifically monitor stretch, which responds to changes in pressure. The most important ones are highlighted here. There are a few other cells, but generally there are three main baroreceptor bodies. Three main centers that are pressure sensitive, monitoring mean arterial pressure. One in each carotid artery, and one in the arch of the aorta. So you only see one carotid artery here, the right common carotid artery. You'd have a left common carotid artery as well. Both of those would have baroreceptors in what we call the carotid sinus. It's a little bulging, noticeable protrusion on the carotid artery itself. The other group, the third group, is in the arch of the aorta, right at the root of the brachiocephalic trunk. And this is responsible for monitoring pressure in the aorta, and we assume pressure throughout the rest of the vascular, or the arterial vasculature as well. So these three places monitor pressure in very sensitive and important areas. Supplying the brain on the left and the right sides, and then supplying the body. Gives you a sense of how important flow is to the brain, and how important a constant supply of blood is to the brain. We always want to make sure there is adequate pressure, which ensures adequate flow to that very important tissue. So carotid bodies, or the two carotid sinuses. Carotid bodies is another word for the group of cells in this area that monitor pressure, and there's some chemoreceptors in there as well. The grouping of cells is a carotid body. But they're in the carotid sinus, and then the arch of the aorta, pressure-sensitive cells monitoring stretch in the arterial wall. Now the question then is, how do we get from pressure to stretch? And what signal's being created? What signal is being monitored by these baroreceptors? The signal is a normal tone, a normal rate of depolarization, a normal rate of firing of these baroreceptors. And I borrowed this heavily from the cardiac rhythm slide a few series of slides ago. This looks a lot like the signal generated by the baroreceptors. They depolarize in proportion to the stretch that they are measuring. So if there's a normal pressure, there is a normal firing rate and what we're going to call a normal arterial tone, a normal stretch in the walls. If blood pressure goes up, the firing rate gets faster. If blood pressure goes down, the firing rate gets slower. So it's the rate of firing of the baroreceptors that the brain, the cardiovascular center, is monitoring. The rate of firing of the baroreceptors. So in the second example, there's a reduced pressure, let's say in the aorta. There's less stretch on the walls of the aorta, and then the baroreceptor in the arch of the aorta would fire less quickly or less frequently. So, what does that do? That signal is always being sent to the cardiovascular center. It's always being interpreted. If it's slower than normal, now the alarm bells are on. I need to do something. I need to restore that firing rate to normal. So, on the flow chart on the last slide, you can follow along with these 3 prongs of action. And you can see them, the efferent branches are shown here. The first thing that we're going to do is to reduce parasympathetic activation. I remember from our discussion a minute ago and from the cardiac output series of slides, when I do that, heart rate goes up. Cardiac output goes up. From my understanding of that equation, that means that I'm trying to bring blood pressure back up. That's a good thing. The second thing that happens is it's going to turn on these sympathetic nervous branches to also increase heart rate, to increase contractility, again supporting cardiac output. And then what's not shown here is this third prong of attack. We vasoconstrict the arteries to increase total peripheral resistance. If the pressure is too low, if the firing rate is too slow, these are the compensation mechanisms to bring pressure back up. They do that through increasing cardiac output and increasing total peripheral resistance. All of those will bring pressure back up. Now, what we've just described here is the negative feedback loop that regulates blood pressure. I just realized this wasn't on. You can still hear me though, right? What we've just described is the negative feedback loop that regulates blood pressure. So if you followed through with our last discussion, you can now read through all of these points and you'll see a lot of the same highlights that we just talked about. 3 prongs of attack if blood pressure is reduced for some reason. Baroreceptors sense it, the stretch levels decrease, the rate of firing decreases, and so we have number 1, decreased parasympathetic stimulation. Number 2, increased sympathetic activity. Number 3, constriction of blood vessels. All to increase blood pressure back to normal, to recover a low blood pressure. Now, all of these responses are nervous. They are mediated by the nervous system. They are virtually instantaneous. So instantaneous, in fact, that you never really even register a decrease in blood pressure. I say blood pressure goes down and then these things happen. In practice, if you stand up and then register blood pressure decreasing in the aorta, these will happen before blood pressure even decreases. It's that important to regulate blood pressure properly. And these are near instantaneous compensations for maintaining blood pressure. We also have chronic systems in place, and they are shown here as well. There's an increase in epinephrine and norepinephrine secreted from the adrenal glands to also bolster, to emphasize, to reinforce the actions of the sympathetic nervous system. And we saw this when we looked at the endocrine system at the end of our first semester. We can cause release of some of these hormones by nervous input to various glands, here the adrenal glands specifically. And then epinephrine mainly, also to some extent norepinephrine, will come around, circulate through the bloodstream, help to increase heart rate, help to increase contractility, and increase constriction of the vessels. Similar mechanisms, but the time course is different. This is a more chronic, long, drawn-out response that supports the immediate acute nervous response. And I bring that up because hormonal control of blood pressure, it's much larger than this and very important in terms of long-term chronic regulation of blood pressure. Really important in situations where you might be chronically dehydrated or have undergone hypovolemic shock if you're losing blood really quickly. You try with all of your acute mechanisms to maintain blood pressure, but if they can't do it, or if a longer term regulation is required, hormonal release is affected to modify mean arterial pressure. So we've seen epinephrine and norepinephrine to help I guess I was boring. Epinephrine and norepinephrine to help bring back up blood pressure through the mechanisms we talked about on the last slide, but there are also hormonal mechanisms that don't acutely affect the heart function or vascular function, but rather increase the amount of blood or try to preserve the amount of blood that's circulating. Now, you don't have to worry about copying this down in a ton of detail and understanding it yet, because this cascade of hormones will be center stage when we talk about fluid regulation at the kidneys. That's coming up. But the point of this cascade is to maintain or increase blood volume, which would support an increase in blood pressure. If there's more stuff being packed into the vascular space, pressure could go up. And so at the same time as we have these acute nervous regulations, we have what I'll call maybe short-term hormonal regulations. We have this cascade of longer-acting, more chronic hormonal regulation as well. Call this the renin-angiotensin-aldosterone system. And without getting into too much detail, angiotensin is something that helps to vasoconstrict. We've seen that and understand how that would help increase blood pressure. And the end goal of this pathway is to increase blood volume to prevent fluid from leaving the body, however you might do that. which would restore pressure in the vasculature. These are longer-term methods of control due to the progressive release and cascading metabolism of hormones. So long-term regulation, where short-term nervous regulation isn't enough, or perhaps those muscles or the nerves innervating those muscles are fatiguing, that's when we need this longer-term, more chronic activation of the hormonal system to help restore blood pressure. And this usually only happens in extreme situations. On a day-to-day basis, you won't have a rapid induction of this pathway as you go about your daily lives. You're drinking water pretty regularly, you've got regular meals, you sweat at the gym, but afterwards you're thirsty, you're not binge drinking too often. Balance, blood pressure is relatively normal, but only in severe cases, hemorrhage, blood loss, dehydration, would these come into play. So that's more complicated. It is more complicated than that. There are a few other hormones that we could mention and reference, and I've included the table here for you to look at if you want to understand how they all intermingle or mix together and the effects that they have, but we'll come back to this largely in this section on the kidneys as well. Now, one last point before we finish this small series of slides. I'm going to cut some of this short. On autoregulation of blood pressure. This is, it really describes what I just mentioned, that you never appreciably see a drop in blood pressure in normal circumstances, because we are so good at the tight, acute regulation and maintenance of pressure. In normal circumstances, any variation in the firing rate of those baroreceptors is corrected immediately. And the whole point is to make sure tissues receive enough blood. Now, building on this idea, the definition of enough blood changes from tissue to tissue. And it changes between different circumstances as well. And the principle of autoregulation describes being able to supply individual tissues efficiently. Not just the whole body at once, they get an average blood pressure or an average flow, but the needs of the individual tissues can also be regulated independently. More often than not, this is due to changes in metabolic activity. Greater demand for blood flow, greater need for substances, greater metabolic activity. And so you can already imagine what tissues I'm thinking of. You probably have some in your own mind already. And as you sit there thinking really hard about what tissues have an increased metabolic requirement, you're generating in the brain. Metabolic requirement has gone up, so blood pressure and blood flow to the brain is probably being accentuated right now. The way that we accomplish this is it's pretty interesting. We don't have many different branches of the nervous system that turn on the vasculature in one region and turn it off in another. Generally, the signal on the nervous side is pretty consistent. But what's different at the tissue level are any of these chemical byproducts of metabolism. And that makes a lot of sense. If there's more of a metabolic demand, there's more of these chemical signals. We can respond to those and regulate blood pressure accordingly. We get a really nice way to titrate and direct blood flow. So classic example, one that really nicely illustrates this point is the transition from rest to exercise. As you sit here at rest, normal blood pressure. Heart rate's beating normally. There's no stress. But if you jumped out of your seat, ran up these stairs, and maintained consciousness, started to run around the block and do a half marathon, all of a sudden, all the changes that we've talked about that occur with exercise are happening. Sympathetic nervous system's on. Blood pressure goes up. Heart rate goes up. Ventilation goes up. The working muscle needs blood. Other tissues like the spleen, the stomach, we don't care about so much during exercise. We can turn blood flow off to those organs. We need it at the muscle. How do we do that? What's interesting about thinking about the transition to exercise is when we turn everything on, it's a sympathetic signal. Sympathetic nervous system is universally active. Heart rate goes up, breathing rate goes up. Those are sympathetic signals. You know what else is a sympathetic signal that we just saw on the other slides? Is vasoconstriction. That's a sympathetic signal. Hold on, if I want blood flow to go to tissues, I don't want to constrict the arterioles. That's going to increase resistance. That's closing them off so there's less flow. That must be backwards. It's not backwards. That's the means through which we regulate the tissue-by-tissue distribution of blood. Step one, shut off blood flow everywhere, or turn it down everywhere. And then only in those locations where we have a high metabolic requirement are we ever going to see whatever these factors are. These factors that are released from muscle or from the heart or from the brain. Whatever those vasodilatory factors are. And this is important because it's only the appearance of those factors that opens up the vascular bed again. So we clamp everything shut, and then only in those places where the tissue is active do we open up the arterial bed. Only in the quadriceps if you're cycling, or the calves if you're running. And that's a simplified point of view. But only in the muscles that are active will you see the appearance of these factors, which allow local blood flow to be proportional to the demand of those muscles. Shut everything off and then open up only the arterial system where it's needed. So nitric oxide is probably one that you've heard about before. That's one of the most potent vasodilatory substances in the body. And it does a really good job of opening up the vascular bed where it needs to be open. When you take something like a pre-workout supplement that has nitric oxide in it and you get that pump that you get before going to the gym, you override all of the body's normal auto-regulation of blood pressure and blood flow. Instead of clamping everything down, your pre-workout nitric oxide supplement is now opening all those vascular beds up. You start to see stars, you can get dizzy, pass out, and faint. So, not a huge fan of those. Alright, I am cutting the rest out because Matt did a really good job in, I think, even back in, lab 3, with the blood pressure animation, understanding how to check blood pressure, measuring systolic, measuring diastolic, the court cough sounds. You know the appearance and disappearance of the sound and what that means in terms of pressure. And I'm deferring our discussion on hypovolemic shock until we get to the kidneys because, one, we don't have so much time now, and I think that it might be more impactful when we talk about hormonal regulation of the kidneys. So I want to summarize this section. We've done all of these main points, which we set out to do at the start, which is fantastic. And today, we tried to get a better sense of the difference between flow and cardiac output, normally I use those interchangeably because there's always pressure. The heart's always connected to the vascular system. There's always resistance, and so cardiac output always ends up being blood flow. But if you remove it from the vasculature, cardiac output is just the amount of blood that's ejected from the heart, or the rate at which blood is ejected from the heart. And if nothing else happens, if it just sits there, blood doesn't go anywhere, it just pools. In order for blood to flow, it depends on pressure and resistance in the vessels connected to the heart. Earlier in this section, we acknowledged, we always talk about cardiac output and flow like there's an endless supply of blood, but we tempered our expectations a bit, realizing that we need a constant return of blood to the heart, and that venous return, usually it's adequate, and it's assisted by those three main mechanisms, the one-way valves, the respiratory pump, and the muscle pump. But in extreme cases, you can compromise the amount of blood returning to the heart because pressures are so low on the venous side. And they're supposed to be. Blood flows from high to low. It needs to be low on the venous side. But you can pass out if you run upstairs too quickly. Mean arterial pressure is the regulated variable on the cardiovascular side. It's sensed by baroreceptors, and then if it needs to be changed, we modify cardiac output or we modify peripheral resistance to keep blood pressure constant. So mean arterial pressure, always monitored by the baroreceptors. They specifically sense stretch, which is directly proportional to pressure, with that basal tone or firing rate. And then if we need to modify pressure, we do that by affecting cardiac output or by affecting total peripheral resistance. We have control over those two things in order to maintain blood pressure. We don't have direct control over blood pressure proper. Questions? That make sense? You good? All right. Now we have at least 10 minutes. And I'm only going to take oh, nope, that's way too far. I'm going to take a few moments just to introduce you to the approach to the respiratory system that we will have in this section and the next section. It differs from lab a little bit. We focused on a lot of the anatomy in lab, and we are focusing less on the anatomy in class. So let me frame how we are going to approach the respiratory system. And I wasn't particularly inventive or imaginative when I came up with these outlines. We're going to talk about some of the anatomy of the respiratory system, explain the physiology of the respiratory system, and then I want you to review the mechanics of breathing. You did this already last semester, but I want you to refresh yourselves on the mechanics of breathing so that in the next section, after this series of slides, we're focusing on gas exchange, hemoglobin, movement of gases, and what it means for gas to move from the lungs. Here we are setting the stage for gas exchange, but we're not talking about it yet. So the way that I want to approach this section is by mainly focusing on the parts that are involved in gas exchange, the parts of the lung involved in gas exchange. And I want to make sure that I do my due diligence and separate gas exchange, ventilation, and respiration. Because initially, The book starts with saying respiration is the movement of gases from the environment through the body, lungs, into the blood, and then the cells. True, that covers a lot of bases, and I find it a lot easier to grasp the concepts if we divide respiration a little bit. Usually, in kinetics, exercise physiology, in our field, respiration is usually only used to refer to cellular respiration. At the mitochondria, using oxygen, producing CO2, that's where we reserve the term respiration to describe mitochondrial cellular respiration. We have different terms for the events that occur upstream. The movement of air in and out of the lungs, not respiration as far as I'm concerned. The movement of air in and out of the lungs is ventilation, and that's different. There's no exchange of gases. There's movement of air and whatever the gases happen to be contained within that air. Ventilation, movement of air in and out of the lungs. And you'll measure this in XPhys, it's just the air moved per minute, or air in a given breath. This gives the opportunity for gas exchange. Ventilation refreshes the air that's in the lower parts of the lung. And I'm crossing this second one out. In your textbook it's still called external respiration. But I think a better descriptor is simply gas exchange. External respiration is movement of oxygen and CO2 between the air and the blood. And so gas exchange, I think, does a better job of describing that phenomenon in my mind. And this is how I frame the topic. Ventilation, the movement of air. Gas exchange, the exchange of gases. Respiration, consumption of oxygen by the mitochondria, production of CO2. Now, we have already talked about the cardiovascular system at length, and so I'm trying to separate these two a little bit, but in practice they're never separate. They always work in tandem. And the connection between gas exchange and respiration is almost exclusively cardiovascular. The cardiovascular system transports what the lung has accomplished. But the respiratory system proper, when we refer to the respiratory system, we think of the lungs, we think of the bronchioles, the bronchi, the trachea, the airways. We don't think of the cardiovascular system, but their roles are very intimately related. So it's important to remember that. Now leave it there for now. We'll break down the components of the respiratory system. I'll get rid of some of them because we're not going to touch on them again when we get back to class on Thursday.